Good morning. My name is Dr. Caroline Triepel. I appreciate all y'all coming out this morning. I'm going to be speaking on the Patient Protection and Affordable Care Act, otherwise known as Obamacare. The Patient Protection and Affordable Care Act, what exactly is it? It's 2,409 pages. It's the largest expansion of the federal bureaucracy in the United States history. It has 159 new boards, commissions, and agencies, 4,000 new healthcare regulation, 150,000 new federal employees, up to 16,500 of which may belong to the Internal Revenue Service. All of these agencies, boards, and federal employees are designed to make me take care of y'all better and to cut costs. So why am I here? I'm getting paid. No, I am not getting paid. I plan to run for office. I have no plans to ever run for office. I'm a much better surgeon than I think I would be a legislator. I'll get more patients this way. Not really. Some patients might come to me. Other patients may choose not to come to me. I am here solely because I care about my patients, I care about my country, and I care about my 4 children. So what I hope to accomplish briefly in this half hour is to discuss what the PPACA proponents are saying and discuss perhaps some points that we can refute, debate, and discuss. And just as importantly, to bring up what the PPACA proponents aren't saying. So when I'm saying PPACA, of course, that's my short way of saying the Patient Protection and Affordable Care Act. So I put out there that within this campaign, we all know how important the budget is, the economy, and jobs. PPACA is a very important component of all 3 of these items. I'm going to briefly discuss the Supreme Court of the United States ruling, which occurred on June 28th. I remember specifically what I was doing on that date. I was at our office in Chesapeake and I was seeing patients. I was seeing patients during the morning, and in the afternoon I was driving to Charlottesville to pick up my daughter to camp. And I knew I wanted to kind of move efficiently through the patients, because once that ruling came out at 10:30 a.m., I just might be a smidge distracted. I was fortunate that at about the time the ruling came out, a patient of mine came in with a partial fingertip amputation. I needed to numb them up and I needed to kind of trim it down. So it was a nice way to kind of get out some of that excess energy and mull about the ruling while I was helping out this patient of mine. But that's what you do when you're a hand surgeon, you kind of work on these things. So the issues before the Supreme Court, the biggie was, of course, is the individual mandate constitutional or not? I'm not going to discuss that too much because we all know it was judged to be constitutional, but not according to the Commerce Clause, but according to the taxation powers of the Constitution. What I want to discuss is the 4th argument that was heard before the Supreme Court, one that did not get a lot of attention at the time because everybody was focused on the individual mandate, but one that is very, very important. That 4th argument in front of the Supreme Court is the law's expansion of Medicaid an unconstitutional intrusion on the states? And the argument before the Supreme Court was this was an exercise in coercion. It was forcing the states to expand Medicaid. And the Supreme Court said, yes, this is an unconstitutional expansion of Medicaid and an unconstitutional intrusion on the states. So now states have a choice. They can keep Medicaid as is or expand it. So short-term implications for the states if they do choose to expand Medicaid. It is oftentimes a leading budget item in most states. And under PPACA, with full expansion of Medicaid, there will be up to 84 million new enrollees by the end of the decade. And an important factor to consider is that states only receive 2 years of federal subsidy. Now let's look at the other side of that coin. Physicians in Virginia, and this does vary from state to state, but in Virginia, physicians are reimbursed 60 cents on the dollar of the cost of care. So let's hone this down even further. Again, taking Virginia as an example. In 2012, Virginia currently has approximately 1 million enrollees in Medicaid, and Medicaid is approximately 17.3% of the state's general fund. If Virginia chooses to expand Medicaid, we will increase our Medicaid enrollment by 41%, and our budget share will increase from 17.3% to approximately 30%. That's huge. So you take this expansion, and let's, on the other side of it, look at the fact that physicians are only reimbursed 60 cents on the dollar of the cost of taking care of a Medicaid patient. What we are going to see if we choose to expand Medicaid is an increased cost burden to taxpayers, but patients won't necessarily have increased access. A physician, to take care of a Medicaid patient, has to take 40 cents out for every dollar and pay to take care of that patient. And as a business model and as physicians, we need to pay our electricity bills, we need to pay our front staff. There's only so much loss that a physician practice can take. So it may sound wonderful to expand Medicaid, and you may even get over the fact that it's going to increase our budget from 17.3% for Medicaid to 30%. But when you couple that with the fact that once these patients have a Medicaid card, it does not guarantee them access to care, that is concerning. Coverage does not equal care. So let's discuss a couple of arguments, there are many, but a couple of arguments that the PPACA proponents are putting out there. What I did for this portion of the talk is I went to the Obama-Biden re-election site and I looked at 4 videos that are there under healthcare. And I would urge each one of y'all, if you haven't had the chance, to go to the website and look at them. They're very compelling, but they are not completely factual or truthful. So I'm going to discuss one, and this is a particularly heart-wrenching one because it discusses a child that was born with a congenital heart defect, and she needs to have 3 surgeries by the age of 18 months. And the parents come on and they say, wow, by 6 months, we had reached 50% of our lifetime cap for her. There's no way. By the time she get the 3rd, she would be at her cap, and boy, we are really thankful that the president's health care law was passed because that saved our daughter's life. And the dad gets on the video and he says, almost tearfully, that he has anxiety attacks. He wakes up and he just doesn't understand how anybody could not think that this law is such a great thing. It saved his daughter's life. And it is very compelling, and it really does pull at your heartstrings. But in order to cut costs, there will be a limit. There is an agency called the Patient-Centered Outcomes Research Institute. This replaced the Federal Coordinating Council on Comparative Effectiveness Research. And I'll put out there that I think the two are probably very similar. The Federal Coordinating Council was designed to calculate comparative effectiveness ratios, where you take the cost of treatment and you divide it by the number of useful life years remaining. And this is analogous to the British NICE board. So I will put out there that perhaps insurance might not have a limit, but your government will. And perhaps in this case, this child would have never known that there were surgeries that were available to save her life because the government would not have allowed it. Now, if you're on Medicare, there's a different board, and we've heard a lot about this board, called the Independent Payment Advisory Board. This is a politically appointed board of 15 individuals. Their sole purpose is to reduce per capita rate of Medicare spending. They will determine covered services and the fees involved. Now, this is a somewhat shocking slide, and I wanted to point out the little yellow bell in the lower right-hand corner. This slide was put out by the Australian Tea Party. And I just want to read it to you because it's difficult to read perhaps the bottom part. But it says, Obamacare, the practical reality. Socialized medicine, die while you wait. America, you have no idea. DMV very quick. Post office, very, very quick. Obamacare, knee replacement, 3+ years and counting. We know. Socialized medicine equals wasting people's lives and killing them to hide costs. Death by bureaucracy. Now the Australians, they really put it right out there. Again, a big concern. Now, I shouldn't say a new issue, but an issue that has gained new attention lately is Medicare. And if you go to the Obama-Biden website, there is a video on strengthening Medicare. And this video discusses closing the donut hole of Medicare D insurance coverage. So if you're looking at your prescription plan, it pays 75% of the first $2,830, and then it covers 95% above $6,000, but in between there's no coverage. So that's the donut hole. So under PPACA, this donut hole will gradually close. So it sounds good, but at what cost are we going to pay to close the donut hole? $716 billion, because that's what's being cut from Medicare to implement PPACA. Provider payment cuts are estimated to be over $400 billion of these savings in Medicare. And I could tell you with the sustainable growth rate, which is something that comes before Congress every year regarding physician payments, that will come into effect this year, or scheduled to, and that alone is going to cut provider payments 26% this year. So, what effect will this have on access for our seniors? Especially when you consider now that approximately 75% of doctors currently either limit or opt out of Medicare. And I know as a hand surgeon in a large medical group, we don't distinguish. We see Medicare, Medicaid, private, no insurance, does not matter. And I will say that even just as a hand surgeon, as a surgeon who episodically takes care of a patient for their carpal tunnel release or their wrist fracture, I have several patients every year who come up to ask, Dr. Triepel, can you please make a recommendation for a Medicare provider because I can't find one. They're having trouble. So no discussion of Medicare today would be complete without mentioning Paul Ryan. I would say that he is probably the big reason why now Medicare has been thrust into the spotlight, because he has a plan to preserve and sustain Medicare. And in this plan, basically discussing transitioning Medicare from a defined benefit to a defined contribution. And there's no change to any patient that's greater than 55 years of age now. Currently, if Medicare continues as is, obviously, it's going bankrupt. I would put out there with PPACA cutting $716 billion and instituting a rationing board called IPAB. That's not best for our seniors. This creates the most choice and sustains and preserves Medicare for years to come. I put up this slide. It's a popular slide, and it's to show the person in the center. This is to introduce her, the Secretary of Health and Human Services. Now, if you look further up to the yellow diamond, you'll see the IRS. This is our new healthcare system, this chart. If you look in the upper left-hand corner, you see the President. Upper right-hand corner, Congress. You see IPAB in there, over to the left. And you see the Patient-Centered Outcomes Research Institute in there as well. Now, if you look way down at the bottom, you see marginalized physicians, and on the other side, patients. Because our new healthcare system is not about physicians and patients. It's about the government. So Kathleen Sebelius, Secretary of Health and Human Services. She is the second most powerful person in the United States behind our president. Oh, by the way, she's the former executive director of the Kansas Trial Lawyers Association from 1977 to 1986. She is an insurance commissioner, and she will determine the quality and standard of our health care and will oversee the implementation and enforcement of PPACA. So what I see is I see a schizophrenia here with what we're being told and what I see as a reality. With Sebelius and PPACA proponents, they say preventive care is free. But we'll get into this in a few more slides. There are $500 billion of new taxes. To me, that's not free. Kathleen Sebelius says we're building and expanding community health centers. But again, we'll get into this in a few slides. There's a very real healthcare shortage with doctors, and that's without PPACA. And then we had the proponent saying, we're closing the Medicare donut hole, but we're also cutting $716 billion from Medicare and have the implementation of IPAB and rationing. So again, we return to this busy chart. Let's discuss what the PPACA proponents aren't saying. Does PPACA achieve its goal? And are there any alternatives? So, does it bend the cost curve down? Because that's what we hear that it's designed to do. And does it cover the uninsured? I'm a physician, I'm a surgeon. I went to medical school not to care for those that have insurance. It's to care for patients. Doctors want to take care of patients. We care about this issue. We're going to look at the effects of PPACA on small business, taxes, doctors, and patients. So spending. This is a little bit of a busy slide, but what I did is when I went to the CBO website. 2012, they state that PPACA is going to cost $1.5 trillion in new costs for Medicaid, CHIP, which is the Children's Insurance Program, tax credits, and other subsidies for the purchase of health insurances through the exchanges. This is going to be offset by $0.4 trillion. So that's pretty close to $500 billion, $0.4 trillion. And this is somehow going to decrease the deficit by approximately $138 billion over 10 years. Now, apparently, I have heard that the CBO has accounting rules that allow for the Medicare cuts to be counted twice. And somehow, that is legal for the CBO. But in reality, it wouldn't work for our checkbooks. Now, Charles Blehaus is a public trustee of Medicare. And he has said recently that PPACA will increase federal spending by more than $1.15 trillion over the next 10 years. And it will add, not take away from, but add anywhere between $340 to $530 billion over the next 10 years. Let's look at the uninsured. There are approximately 47 million. And this was a study done by the Republican Policy Committee in 2008. And if you look at this pie, there's two halves. There's the bottom half and the top half. I like to look first at the green slice of the pie. Green slice of the pie, approximately 9 million patients, individuals earning more than $75,000 per year. These are likely some of the more healthy new graduates, get the good jobs, they don't have insurance, but they could purchase insurance. So that's 9 million out of the 47 million. We're going to move down to the bottom of the pie. Another 9.7 million patients that are eligible for government programs, such as Medicaid, and they choose not to enroll. Then we're going to move one more slice to the beige, and you'll see there's approximately 6 million patients who are eligible for employer-sponsored programs, and again, choose not to participate for whatever reason. So that 47 million uninsured now becomes roughly 23. Now we'll move to the top half. You've got 5 million legal immigrants, approximately 5.2 million illegal immigrants, and the orange slice, 12 million Americans without affordable options. So whether you look at it as 12 or whether you look at it as 23, this is what we want to carry forward. Currently, we have approximately 250 million insured Americans. And whether you call it 12 or 23, or even the number that's commonly batted about in the press, 30 million, you can see that there's around 90 to 95% of Americans are insured, 5 to 10% are uninsured. So, CMS analysis in April 2010, 1 month after the bill was passed. By 2019, after full implementation of PPACA, 23 million Americans will still remain uninsured. So I put out there, what have we accomplished with 159 new boards, agencies, and committees? What have we accomplished with a 1.1 or 1.5 trillion dollars, depending on the day? What have we accomplished if, after full implementation, we still have 23 million Americans that are not covered? This does not change the level of the uninsured, and it adds an unfathomable level of bureaucracy and cost. Now we're going to move on to the effects on small business. Now, I was given a copy of a testimony that a friend of a friend was asked to give down in South Carolina in front of Congress. And these are his notes, not mine. Small businesses employ approximately 57.7 million Americans compared with large corporations, which are about 60, so roughly equal. For small businesses, current government regulations cost about $10,000 per employee, which is 36% more than larger firms. And in a recent U.S. Chamber of Commerce study, 75% of small business owners see the new healthcare law as an obstacle to hiring new employees. And I can tell you, I've heard this firsthand in speaking in another area in Virginia Beach, where after a talk, a woman who owns a daycare facility stood up and said, you know, she has currently 60 employees and she was going to open, or she was looking into opening another branch. And now instead, she's looking at trying to get under those 50 employees so she doesn't have to provide health insurance or pay a fine. So I put out here again that this new law has a profound impact on our economy and our jobs that we're hearing so much in the campaign about. This particular small business owner in South Carolina goes on to say, I thought that we, meaning small business and the government, were a partnership. You create rules, laws, and regulations that are specific, reasonable, and ones that are understandable. They aren't meant to be punitive and destroy the backbone of America's small businesses. In return, we take calculated risk, hire people, build businesses that are profitable, and pay taxes on those profits. No government created a sustainable society by its government creating jobs and becoming a global economic model to emulate. Would you like a few reminders of abject failures? Russia, Cuba, the entire Soviet bloc countries, and North Korea. If you regulate us to death, surely you will suffocate us all. And that doesn't matter if you're a small business owner, that doesn't matter if you're a doctor, and that doesn't matter being a patient trying to find care. If you regulate us to death, we will all suffocate. Next, we're going to describe taxes. There are 20 new taxes within the new healthcare law, $500 billion that will be raised over the next 10 years. And these are taxes that are not necessarily germane to healthcare. There are taxes on the sale of homes. There are taxes on using a tanning booth. 75% of these taxes will be borne by those making less than $125,000, the middle class. Here's one effect of the medical tax, the medical device tax. Cook Medical, July 30th, canceled plans to expand 5 plants, citing the $15 to $30 million that the company will have to pay on the medical devices tax as the reason. So again, I would say that this law has a profound impact on our economy and on jobs. Papa John's Pizza, this is published in the Huffington Post. They stated that they will have to increase the price of their pizza so that they can provide health care insurance. The National Restaurant Association said that PPACA may affect most restaurants' ability to maintain their narrow margin of profits. I'll put out there, this is going to limit restaurant openings. It's going to limit the number of employees that these restaurants employ. Again, this law is about the budget, the economy, and jobs, as well as what we hear about healthcare. So why are doctors concerned? More regulations. These regulations detract from our ability to take care of patients, and it adds to our overhead. Example that I give is when we have our monthly meetings to discuss how we take care of patients and the business that is medicine. Easily an hour and a half out of our last 2-hour meeting was all about how to comply with these new regulations. And these new regulations don't help me take care of my patients. I'll give you one example. We're required to electronically prescribe a certain number of prescriptions for Medicare patients. And if we don't, we get penalized financially. Now, as a surgeon, we don't prescribe blood pressure medicines. We don't prescribe bone density medicines, any of that stuff. Typically, it's either a short duration of narcotic medication for surgery or maybe some anti-inflammatories. Now, the narcotic medication you can't send electronically. So, we have to prescribe a certain number of anti-inflammatories electronically for our Medicare patients or we get dinged. That has nothing to do with my ability to take care of a patient. And yet we have to spend our time not focusing on patient care, but on jumping through a hoop. And we have to have personnel in the background to monitor if we're compliant. Very, very frustrating. We're very concerned about these rationing boards because these rationing boards are going to put physicians in the position of potentially having to violate the Hippocratic Oath, do no harm. And if we do go ahead and recommend a correct treatment plan that the government doesn't endorse, then the physician will suffer the consequences. They'll initially start out being monetary, we won't participate with you or what have you, but there have been some members of Congress that have shared with some physicians out there that repeat offenders will be put in jail. What do you think this does to us? There's this propagation again that insurance equals care, and it doesn't. Let's briefly discuss the doctor shortage. Right now, without PPACA, there are 25,000 new physician graduates in the United States, and there are currently 35,000 physicians retiring each year. So right now, each year, we have a 10,000 physician deficit being created. In 10 years, that's 100,000. This has nothing to do with PPACA. This has nothing to do with the fact that there have been multiple studies, such as this one in Investor's Business Daily in 2009, where it said that approximately 45% of physicians would consider retiring. I would. My brother, who's an OBGYN in South Carolina, he is, because we want to practice medicine. We want to help patients. We don't want to be forced by a bureaucrat to say how we need to take care of somebody. So we're going to add 30 million patients. we're going to have 100,000 physician shortage in 10 years. And we're going to have, because of the baby boomers, a 30% increase in Medicare enrollment. How are we going to take care of these patients? So I'll put out there that the effect on patients will have decreased access to care, we'll have decreased choice in the care and the provider that we have, decreased quality of care, increased wait time, and increased cost. We will eventually have our care rationed by the Secretary of Health and Human Services, Kathleen Sebelius, or CMS. We're going to end on some more cheery notes. Isn't there a simpler way to cover the uninsured and cut costs other than bankrupting our country, rationing boards, and destroying the doctor-patient relationship? There are alternatives out there, contrary to what the general media would have you believe, and they're great. We're going to go through a couple of these right now. First off, I want to briefly mention there are a few doctors groups out there. There's Docs for Patient Care, there's Doc Squads, there's DPMA, or Doctor Patient Medical Association, there's the American Academy of Physicians and Surgeons. There are multiple groups out there, all with similar but good ideas for true healthcare reform, because our country, we absolutely need it. So briefly, we're going to discuss two. There's Paul Brown. This is his bill. I can hold it up because it's not 2,604 pages. It's only 51. You can download it easily on his website, and it's called the Option Act. There's a second one, and this is even shorter, 17 pages. Representative Tom Price in Georgia, his plan called the Empowering Patients First Act. Now, I don't know what it is about Georgia, but both of these bills come from congressmen in Georgia who happen to be physicians. So I think there's something going on down in Georgia. First, we're going to discuss the Option Act, Paul Brown's act. How does he propose to cover the uninsured? By 159 new boards, agencies, by a tax. He proposes covering the uninsured by charity care credit. So, if I'm a private physician and a patient comes in without health care insurance and needs to have care, I take care of that patient, and then that's written off of the business's taxes. That's a pretty simple way to try to bend the cost curve down and cover some of these patients. How does Paul Brown propose to cut costs? Number one, repealing the floor on medical expense deductions. Currently, you have to have, might be 7.5% of your gross income. If your medical expenses exceed that, you can write them off. If it's below that, you can't. And they're raising that ceiling to 10% so they can get more money for this project, PPACA. So Paul Brown proposes repealing the floor, expanding the use of HSAs, which we'll touch upon in a couple of slides. That will help drive down medical costs, and also to allow insurance to be sold across state lines, just like, say, car insurance. Increased competition, increased market forces, that will drive down costs. He also, like Paul Ryan, proposes increasing choice when it comes to Medicare and creating a Medicare Premium Assistance Program, where basically you have your allotment for Medicare, and you could either slide into Medicare or use that for a private plan. Tom Price, how does he propose to cover the un- and underinsured? By tax credits for health insurance for low-income individuals. So you're given a tax credit, they can go out and purchase insurance. And also state-run high-risk pools. Currently, 35 states have high-risk pools, and Tom Price's bill would increase these and help with these patients who need to have health insurance but have a pre-existing condition get insurance. Now, how to cut costs? In Tom Price's bill, allow insurers, again, to sell across state lines. You see a common theme between Paul Brown and Tom Price's bills. Medical liability reform, which Paul Brown's bill does not have in it, and Tom Price's does. We'll touch upon that in a few slides. And the last two bullets really kind of belong together. Small business fairness and individual membership associations. What both of these agencies or groups do is, if you're in a small business, you can get together with the other trades, other plumbers or what have you, pool together and use your resources together to buy insurance. And in a perfect world, that can be across state lines. It also allows individuals to do the same thing. Tom Price's bill increases choice by creating an equal employer contribution rule. What that is if you go to work for a company and they provide insurance, they could also provide you that same amount that they would use to purchase your insurance so that you could go out and buy your own policy. That way, your policy would stay with you wherever you go. Think about what that would do to pre-existing conditions as well. Tom Price also advocates improving beneficiary choices for Medicaid and CHIP, similar to what Paul Brown and Paul Ryan both have put out there. So, 3 R's of sustainable reform: medical liability reform, insurance reform, and personal responsibility. First, we'll touch upon medical liability reform. After one of my talks, a tax attorney came up to me and said, the United States has 4% of the world's population, but 94% of the world's lawsuits. I said, that's too bad to be true. You've heard things are too good to be true. I thought, this is too bad to be true. So I researched it, and he was wrong. He was wrong. The United States has 5%, not 4%, 5% of the world's population and 94% of the world's lawsuits. There is something wrong with that. Now you'll see in this slide, there's a picture of me and a man that's not my husband, okay? That man is my brother, the OBGYN in South Carolina. And I put this slide up here, that picture, to remind me to tell a story. When I was visiting my mom, and my mom lives in the same city as my brother in South Carolina in April, he came back from his practice meeting. And in his practice meeting, their malpractice carrier had come to them and said, we might have to drop coverage of your practice. And their practice has not lost a single lawsuit. Now, the reason that this medical liability insurance carrier might have to drop my brother's practice is because there are so many lawsuits that are brought up against this OBGYN practice. And the cost of defending each one is approximately $500,000. So this practice is doing nothing wrong except for being around a bunch of lawyers. And yet, their carrier might drop them because they can't afford them. They don't know what they're going to do yet. They don't know if they're going to have to limit the patients that they see, they're going to have to leave the county, or if they're just going to have to disband. They still haven't decided. So the cost of defensive medicine. Approximately 90% of doctors perform defensive medicine. Now, this is in a study. And I would say the other 10% don't realize that they're doing it. Physicians attribute 34% of overall healthcare costs, to defensive medicine, whether that's ordering an MRI or ordering some additional blood work that's just not necessary. 34% of healthcare costs. There's been one study that shows that defensive medicine costs the United States $150 to $200 billion per year and can add up to $1,700 to a family policy. Okay, think of what we could do with $1,700. I could do a lot with it. Medical liability reform needs to incorporate medical specialty courts, not bureaucrats, that determine the merit of a case, and the judgments should be calculated by an expert panel. There should be caps placed on non-economic damages, and something that would really help is a loser pay system. So if a patient has come up to me and says, Dr. Triepel, I have a lawyer and I'm going to sue you because my thumb is not good. I know I came in with an infection. I know I came in with a dislocation along with that infection, but I'm going to sue you because my thumb's not right. And we go to court, and the panel sees that as soon as that patient was seen by me, I admit them to the hospital. I have infectious disease consult on them. I have internal medicine consult on them. I operate them on a right away, and see that everything was done according to the standard of care. And he loses, his lawyers pay. I've had a type of event occur such as that. That would cut frivolous lawsuits. In Tom Price's bill, he proposes limiting non-economic caps to $250,000. And Texas does that currently. He also proposes limiting lawyer fees, because at the current time, within Virginia, a malpractice lawyer will take 40% of a judgment, 40%. And establish healthcare tribunals to help determine the merit of a case before a case would go forward. So again, just some examples of current malpractice. In Virginia right now, we have a $2 million aggregate cap, so for economic and non-economic damages. And this was a recent agreement between the Medical Society of Virginia and the Virginia Trial Lawyers Association. It was thought to be this great big win. And it increases $50,000 per year up to year 2032. You can contrast that with Texas, where there's a $250,000 non-economic cap. And then the states are all across the board. We're going to move on to insurance reform. Health insurance, and I didn't know this until I started really delving into this issue. It wasn't tied to employment until World War II. World War II, there are only so many able-bodied men that weren't off in war that could be employed. And so there were salary caps that were put out there that what these workers could be paid. So an additional way to attract workers to your employment was to offer them insurance. It's not sold at a true free market like auto insurance, and is heavily regulated by the states and burdened by legislative mandates. These are expensive options that must be included in a policy, and they're not truly necessary. True insurance covers the cost of catastrophic loss, such as your house burning down, such as totaling your car. It's not what we have right now, which is prepaid health care, where everything in the world is supposedly paid for, except if you look at the taxes on the back end. True insurance is portable, so where you go, it goes. Again, that will limit pre-existing conditions a lot. So insurance reform, we've heard this a few times before. We need to eliminate the interstate restrictions on the sale of health insurance. We need to eliminate the dependence of insurance on employment. If you want to get your insurance through employment, fine. If you want to get your insurance not through employment, you should have the same opportunity to do so. We need to give the same tax breaks to individuals as we do to employers. We need to allow small businesses and individuals to pool resources. We need to further foster high-risk pools for pre-existing illness and encourage HSAs. So briefly, HSAs, they incentivize consumers to control costs. So I can get an MRI down the street for $400 less than I will, right down the hall. I'm going to go down the street and save money. That's going to help control costs. Stimulates market control and the cost, and it stimulates competition. And there have actually been some studies. The Mackinac study for public policy showed that $200 billion, again, per year would be saved with HSAs. Just think about it. If we have HSAs and we have true liability reform, just think about what that alone could do to healthcare costs. And what the money that is not used in your HSA, it stays with you and it grows with you. This would empower the individual. Our last portion that we'll cover is personal responsibility. The United States really does a good job at a lot of wonderful things and also some not so wonderful things. such as having the leading rates in obesity, tobacco-related diseases, and preventable injury. Determinants of individual health and early death. 40% are due to lifestyle and behavior. So if we get ourselves healthy, that's going to help decrease healthcare costs. If you compare the rates of obesity in the United States and Canada and the UK and Canada, 20%. The United States, 30%. We could fix that. We could take a chunk out of diabetes. Number 2 cause of early death, genetic makeup. Okay, that we can't change. Number 3, social and environmental factors. And the 4th cause of early death, only 10%, lack of access to medical care. Lack of access to medical care is not what we need to focus on. We need to focus on personal responsibility, insurance reform, liability reform. So the promises of PPACA. Barack Obama had said that the average family premium would decrease $2,500. And the reality is CBO estimates that our premiums will increase by $2,100. It's a spread, that's a delta of almost $5,000. That's a big error. We've been told that it's going to cost $938 billion. Reality, depending on the day, it's $1.7, sometimes $2.5 trillion. It's at least double what we were told that it was originally going to cost. We were told in March of 2010 it was going to decrease the debt, $138 billion. But Mr. Blehaus, the Medicare trustee, he begs to differ. In April 2012, states it's going to increase by $340 to $530 billion. So I'll propose that we need to get ourselves out there and meet new people, not necessarily like-minded individuals, but meet new people and try to educate our friends about what we see in the law. We need to get conservatives into office. And once they're into office, hold their feet to the fire. Keep them out of the Washington machine that tends to corrupt. We need to repeal and replace PPACA with a law that actually does cut costs and help our uninsured patients. Thank you all very much for your attention.